the team music. I hope it's Munster's upcoming thrashing of Leinster over the weekend. And I've been asked to talk about trauma, and the title I was given was Game Changers and Game Changers Coming Down the Tracks. I changed the title a little bit. So what I'm going to do is give you a flavour of some of the interesting articles that I've come across in the last few months, and some interesting things that might be coming down the pipe in the next year or two. Disclaimer, I would encourage you all to read these papers yourselves and make your own decisions. I'm just going to touch on them and the author's findings. This is not an appraisal session, but please do go and read the papers yourselves. Henry Wang, who's a well-renowned EMS researcher who's around the US, currently in Alabama, published in the EMJ recently, looking at the association of advanced airway management with poor outcome. And essentially what they did was they took a cohort of patients from another trial, retrospectively analysed whether advanced airway management, which is essentially intubation or supraglottic airway replacement, was associated with a 28-day mortality when compared with ED, advanced airway management. Needless to say, in the setting of traumatic brain injury, there was an odds ratio of 1.57 for poor outcome for 28-day mortality when the patients had intubation or advanced airway management in the pre-hospital setting. Worse again for the patients who had hemorrhagic shock, again did very poorly, and they were 5 times more likely to die if they had advanced airway management in the pre-hospital setting. Yet again, another nail in the coffin for pre-hospital airway management. We hear a lot about these. There are lots of articles which fly in the face of advanced airway management by either paramedics or other practitioners in the pre-hospital setting. There are some in support, and you can go look at the literature yourself. I just thought this was an interesting article from a guy that's very well published and has been a proponent of airway management by pre-hospital practitioners for a long time. Relating to some of the talks we've heard this morning, this particular article, which was published online, Down to Surgery recently, is a database study looking at the association of helicopter transport for patients with traumatic brain injury. They took a large US database over a couple of years, a huge number of patients in it, nearly 210,000, were transported to either level 1 or level 2 trauma centres with traumatic brain injury. And they were measuring the in-hospital survival after SAME. The majority of patients were taken by ground EMS to either the level 1 or level 2 trauma centre. Needless to say, as you can imagine, the patients taken by helicopter tended to be sicker and more likely to die. So they had to do some very statistical analysis to try and remove some of the confounders there and match them up. So what they showed once they had done their statistical witchery was that the odds ratio for survival if you were taken by helicopter to a level 1 trauma centre with a traumatic brain injury in the US was 1.88. So you were nearly twice as likely to survive if you had helicopter transport to a trauma centre compared to ground transport. They came up with an NNT, a number needed to treat, to save one life of 17. We had a discussion in Journal Club this morning about NNTs. 17 seems ambitious, and as I said, I'm not going to analyse this paper from a Journal Club point of view, but you can draw your own conclusions on that. But the authors conclude that helicopter transport for patients with TBI improves survival in the setting that they looked at. This particular article was published in the Journal of Trauma and Acute Care Surgery recently. We've heard a lot about pre-hospital hypertension, damage control resus yesterday in particular. This is a subgroup of a larger study. It's a prospective multi-centre trial looking at goal-directed resuscitation in patients with hemorrhagic shock. Patients were characterised into either large or high, as they described, or low volume fluid administration, depending on the volume they were given. And similarly, they're described into either a group that were hypertensive or not, depending on their systolic blood pressure. As you can see here, for patients who had systolic blood pressure greater than 90, the hazard ratio for 30-day mortality was significantly increased if you were given fluids. For patients who were hypotensive at scene, the results were less spectacular. So the authors concluded that where patients were not hypotensive, that crystallite administration was associated with an increased risk of dying. The hazard ratio, as I mentioned, is almost 2.5. Where patients were hypotensive, and this flies in the face of what we heard yesterday a little bit, that mortality in patients with corrected pre-hospital hypertension was 13% versus 21% in those with uncorrected pre-hospital hypertension, suggesting that patients who are hypertensive following trauma in the pre-hospital setting should get some fluid. Obviously more analysis is required. The PROM trial, they've looked at what essentially is the optimal blood pressure to decrease the likelihood of poor outcome in patients with traumatic brain injury. We know that the concoction of, or the combination rather, of hypotension and hypoxia is very bad in patients with brain injury. So we've always been taught that keeping the blood pressure above an antisystolic is good. Their initial data suggests that number is nearer to 144 than it is 90. So that should provide some interesting information in years to come. They've done some other stuff as well, and have showed that low GCS was associated with poor outcome, poor survival, etc. But I think in time to come we will learn a lot more from this database. Just to mention two trials briefly, which might be interesting. This rescue shock trial is looking at estrogen, a single dose in patients with hemorrhagic shock, hoping to again improve and decrease the likelihood of coagulopathy. This is for guys as well, so we'll all be in this one. And I think Dave referenced this one later, the fibrinogen in traumatic coagulopathy. Again, looking at the pre-hospital administration of fibrinogen. It's currently ongoing feasibility study and will be underway in Austria in time to come. So I hope that's just giving you a little taste of some of the things that are coming down the pipe and some interesting stuff that you might come across. But do please go and read the papers yourselves. It should give you a little bit more information. Thank you.